You know, in our high-tech world of gene sequencing and incredible imaging, you'd think the most powerful tools in medicine are the newest ones, right? Well, what if I told you one of the most critical diagnostic tools we have is a staining technique that's over 140 years old? It's a simple, fast procedure that can literally be the difference between life and death.
And here he is, our lead detective, Hans Christian Graham. Now you gotta love this part of the story. Working in Berlin back in the 1880s, Graham wasn't trying to invent some universal, world-changing test for bacteria. Not at all. His goal was way more specific, and his incredible discovery was really just an unexpected but brilliant side effect of his research.
You see, Graham wasn't actually trying to stain bacteria just for the sake of it. His real problem was trying to make the bacteria he was studying stand out from all the lung tissue cells surrounding them. He was just trying to differentiate the invaders from the host. And in doing that, he stumbled upon a method that neatly divided almost the entire bacterial world into two massive distinct groups.
So that's the big question, isn't it? Why does it work? Why does some bacteria grab onto a purple dye and refuse to let go, while others just get washed out and take on a pink color instead? Well, the entire mystery, the whole secret, is solved by looking at just one specific structure, the bacterial cell wall.
And this diagram right here, this explains everything perfectly. On one side you have a gram-positive cell wall, and on the other, a gram-negative one. I mean, you can't miss that massive difference, right? Look at that thick layer. That stuff is called peptidoglycan, and that is the secret to the entire gram stain.
Let's break that down. So gram-positive bacteria, they have this massive, thick wall of peptidoglycan. Think of it like a dense molecular mesh that's really good at trapping things. In contrast, the gram-negative bacteria have a much thinner layer of peptidoglycan, and it's sandwiched between membranes, including an outer one that's full of lipids or fats. And it's those lipids that make all the difference when we try to wash the dye away. So here's what we're going to cover. First, we'll break down the 4 basic parts that make any gram stain tick. Then, we're going to get into the nitty-gritty, the actual ingredients, the stains, the mordants, that super important decolorizer, and the counterstains. And to wrap it all up, we'll see how all these pieces come together to make the powerful diagnostic tools that labs rely on every single day.
All right, let's start with the basics. Every single gram stain out there, no matter how it's been modified, is built on 4 fundamental principles. It's kind of like trying to understand a high-performance engine. You can't just jump in. You've got to know what the pistons and the crankshaft are actually doing. It's the exact same idea here. You really got to master the basics first.
Okay, so think of any gram stain procedure as a little 4-act play. Act 1, the primary stain. Act 2, the mordant. Act 3, and this one's the big one, the decolorizer. And for the grand finale, Act 4, the counterstain. Each step is essential and builds on the one before it to give us that final, clear picture.
So first up, we hit it with the primary stain. Honestly, just think of it as the first coat of paint. It's a basic dye, which means it's positively charged, and it's naturally attracted to the acidic, negatively charged stuff inside the bacteria. So boom, at this stage, every single bacterial cell on that slide turns a deep, dark purple.
Okay, next comes the mordant. I like to think of this as a chemical lock. What it does is it grabs onto that primary stain and forms this big, bulky complex that gets stuck inside the cell wall. This works especially well in gram-positive bacteria because their cell walls are super thick. They hold on to that dye complex like a fortress.
And now, we get to the most important step of all, the decolorizer. This is the moment of truth. This is where we separate the two groups. The solvent, which is what the decolorizer is, completely washes that big purple dye complex right out of the gram-negative bacteria. Why? Because their cell walls are just too thin. But the gram-positive bacteria? Nope. Their thick, sturdy walls hold on tight to that purple stain.
Last but not least, we add the counterstain. Now, the gram-positive cells, they're already completely full of that purple dye, so this new color doesn't really do anything to them. But the gram-negative cells, they're now colorless, so they just soak up this new stain and turn a really distinct pink or red. And just like that, you've got 2 different groups, crystal clear under the microscope. Okay, so now that we've got the 4 basic jobs down, let's look at the actual ingredients that scientists have played with over the years. We'll start with the primary stains and the mordants.
So, Christian Graham's very first recipe used a dye called aniline gentian violet. Pretty soon, people realized they could improve on it with crystal violet, which was just more stable.
But of course, the innovation didn't stop there. You had scientists like Hucker who came along and tweaked the formula, adding ammonium oxalate to make it last longer on the shelf. Then there was Burke, who added sodium bicarbonate to make the whole thing more alkaline, which actually made it work better.
And this really shows you just how adaptable this whole process is, right? Graham's original dye worked, but it was kind of unstable. Jensen went with methyl violet because it was more reliable. Burke's version, being more alkaline, helped the stain bind even stronger. And then you have Weigert, who cooked up a totally special formula, carbol-gentian violet, specifically for the tricky job of staining bacteria that are hiding inside tissue samples.
When it comes to the mordant, iodine is pretty much king. It's the key ingredient for creating that big, clunky diiodine complex we mentioned earlier. Now, the two most common recipes you'll see are Graham's iodine and Lugol's iodine. They've got the exact same stuff in them, iodine and potassium iodide, just mixed with a different amount of water. And that slightly different ratio just changes the final concentration a bit.
Okay, now we're at the decolorizer. And seriously, I can't stress this enough. This is the make or break moment of the entire process. Everything, and I mean everything, depends on getting this step just right. It is the one single action that separates gram-positive from gram-negative.
Yeah, pretty much everyone agrees it's the most critical step in the whole procedure. And here's why. If you use too much decolorizer, you'll accidentally wash the purple stain right out of the gram-positives, and you get a false negative. Use too little, well then the gram-negatives will stay purple, and you get a false positive. It's a really, really delicate balance.
So, your two main choices here are alcohol and acetone. A good way to think about it is that alcohol is like a gentle stream of water. It'll get the job done, but it's slower, more forgiving. Acetone, on the other hand, that's like a high-powered pressure washer. It's incredibly fast and strong, but man, if you're not careful, you'll just strip the color off of everything. It really requires a ton of precision, like we're talking a matter of seconds.
And you can totally see these different philosophies in action. Graham himself, he played it safe with the slower absolute alcohol. Then you have Kopilov and Biermann, who went for pure, super fast acetone. And then you get these really specialized approaches, like Weigert's aniline xylol for tissues, or Preston and Morell's really unique iodine-acetone mix.
All right, so we've stained them, we've locked it in with the mordant, and we've decolorized. Time for the final touch, the counterstain. This is the step that makes the invisible visible again. It lets us see those gram-negative bacteria that we just washed all the color out of.
So back in the day, Christian Graham used something called Bismarck brown. But honestly, the contrast just wasn't that great. Today, the gold standard is safranin. Its bright pinkish-red color just pops against the purple gram-positives. But hey, for specific jobs, you need specific tools, right? For nasty pathogens like gonococcus, neutral red is the way to go. If you're trying to spot really tiny gram-negative rods, a dilute carbol fuchsin gives you a much more intense color. And for looking at tissues, carmellum is the go-to.
So we've looked at all the individual pieces of the puzzle. But how do they all get put together into a complete, working recipe? Let's check out a few of the most important modifications that you'll find being used in labs and clinics right now.
First up is Hucker's modification from way back in 1921. This thing is a total workhorse in general microbiology labs. It uses that stable crystal violet we talked about, standard Graham's iodine, a slightly more forgiving 95% ethanol for the decolorizing step, and that awesome high-contrast safranin. It is just a really, really well-balanced recipe.
Okay, now let's compare that to Jensen's modification. This one is purpose-built for looking at nasty stuff like pus or other fluids from an infection. We call that exudates. And its goal is to find really dangerous bugs like gonococci or meningococci, the things that can cause meningitis. And look at the key difference. It uses neutral red as the counterstain because it makes those specific pathogens easier to see. I mean, that's not just some tiny technical detail. That's a specific choice that helps doctors diagnose life-threatening diseases.
Then you've got Weigert's modification, which is for a totally different ballgame, histology. We're talking about finding bacteria that are hiding deep inside body tissues. So as you can imagine, the ingredients are super specialized. It uses that carbol-gentian violet as the main stain, a really unique decolorizer called aniline xylol, and carmellum as the counterstain. And look at the times. They're way longer because the stains need that extra time to soak into the dense tissue.
And then, check this out. In 1962, Preston and Morell came up with a simple but totally brilliant idea. They standardized their entire method so that every single step, from the stain to the counterstain, took exactly 30 seconds. This was an absolute game changer for consistency. It massively cut down on human error and meant that results were way more reliable from one lab to the next.
All right, Let's dive into a skill that's absolutely fundamental for anyone in microbiology, interpreting a gram stain. And look, this isn't just about telling purple from pink. It's about learning to read a story that can make all the difference in a clinical setting. So take a close look here. You can see the host cells, right? But what about those little dots hiding inside? Yep, those are bacteria. So what's the deal? Are they just hanging out, or are they a sign of a real invasion? Where they are is a massive clue, and that's exactly what we're going to learn today, how to read these signs step by step. First things first, the art of interpretation. And the one thing you've got to remember is that this is a system. It's a structured approach, not just a random peek through the eyepiece. We break it down into two big stages. First, you look at the quality of the specimen, and then you zero in on the microorganisms. Okay, so we always start with the low-power assessment. Before you even think about hunting for bacteria, you need to get the lay of the land. You're scanning the slide to get a feel for the overall quality of the sample you're working with. So what makes a sample good versus poor? Well, a good sample, one that likely came from a real infection, is going to be loaded with white blood cells, the body's emergency response team. A poor sample, on the other hand, might just be contaminated from the surface, and you'll see a lot of squamous epithelial cells. Getting this right from the start is absolutely crucial, because it tells you if you're looking at something that actually matters clinically. And here is a perfect visual of what I'm talking about. On the left, see that? The field is just crowded with those white blood cells, or PMNs. That just screams inflammation, right? Infection. Now look at the right. You see those big, flat, squamous epithelial cells? That suggests your sample might just be some saliva or skin cells, and not from the actual site of infection. Okay, so once you've decided if the quality is good or not, what's next? Quantification. We've got to turn what we see into actual data. That means systematically counting the host cells so we can create a standardized report. So how do we do that? We use a system like the one in this table. It's a simple 1+ to 4+ scale. For instance, if you're seeing less than 1 cell per field, you report that as 1+ or rare. But if you see more than 25, that's a 4+ or heavy. This gives everyone a consistent way to talk about the number of epithelial cells and PMNs. We've got the big picture. Now it's time to zoom all the way in. We're switching to the high-power oil immersion lens. Our focus is shifting now from the host's response to the actual microorganisms themselves. Let's get to the good stuff. Under oil, there are 3 main things you're hunting for. First, the morphology. What do they actually look like? Second, where are they? Are they inside the host cells, that's intracellular, or are they just floating around outside? And third, just like we did with the host cells, we've got to quantify them. And hey, this should look familiar. We use that same 1+ to 4+ system for the microbes, but the numbers are a bit different because we're at a much higher magnification. Here, less than 1 per field is rare, and more than 30 is heavy. It's just a standard way to report how much bacteria or yeast is really there. Okay, you've found the little critters. Now, how do you actually describe them? That brings us to section 4, using the specific, precise language of microbiology. This isn't just being picky. Using the right terms is absolutely critical for an accurate report. Let's look at a classic example. This right here is a clue cell. See how that epithelial cell is just completely coated in bacteria? So much so that the edges look all fuzzy and indistinct. Finding these is a huge diagnostic clue, especially for things like bacterial vaginosis. And here's another key term you need to know, pseudohyphae. Now, they might look like long filaments, but they're really just chains of individual yeast cells that haven't broken apart after budding. This look is a total hallmark of yeast, especially Candida species. Hey, remember that very first slide we looked at? Well, here's the payoff. Seeing bacteria inside a white blood cell? That's a huge deal. This image shows us gram-negative diplococci, those little pink pairs, tucked right inside the PMNs. This is the absolute textbook sign of a Neisseria infection. Sometimes even the way a single bacterium picks up the stain tells a whole story. This is called bipolar staining. The ends of the rods stain darker than the middle, giving it this classic safety pin look. It's a famous feature of some pretty serious pathogens, like Yersinia pestis, the bug that causes the plague. So, to make sure your report is complete, you need to hit these 4 key points every single time. 1. The grammar reaction. Is it positive, so purple, or negative, so pink? 2. The shape. Are they spheres, cocci, or rods, bacilli? 3. The size. And 4. The arrangement.
Are they in clusters, pairs, or chains? Get those 4 down and you're golden. Phew, we've covered a ton of ground, huh? From the big picture all the way down to the tiny details. So let's bring it all home and put everything together in our final section. Let's lock in this systematic process. Here it is, boiled down to 4 simple steps. Step 1, assess the specimen quality on low power. Step 2, quantify the host cells, still on low power. Step 3, switch to high power to find and quantify the microorganisms. And step 4, use that precise language to describe and report everything you found. Do this every time and you're not going to miss a thing.
So let's jump into a few clinical cases where this is just a total game changer.
So, imagine this. A patient comes into the ER with a high fever, a stiff neck, and they're confused. All the classic signs of meningitis. This is a massive medical emergency, and the doctor needs to know what's causing it, like right now.
And get this, in a staggering 60 to 90% of patients with bacterial meningitis from the community, a simple gram stain of their spinal fluid gives a rapid, accurate ID of the bug. Now that's not just a statistic. That's a critical head start that directly changes how that patient is treated.
And it's not just fast, it's also incredibly specific. We're talking 97% specificity here. That high level of accuracy is what allows doctors to start the correct antibiotic therapy right away. No guesswork, just immediately attacking the right pathogen. That speed and precision can literally be the difference between a full recovery and severe brain damage or even worse.
Okay, let's switch gears to another critical situation. The lab gets an alert. A blood culture bottle is positive. That means a patient has bacteria in their bloodstream. The clock is officially ticking to get them on the right antibiotic.
So a gram stain done right from that positive bottle is absolutely critical. It gives the first clue about what kind of bacteria we're dealing with, which immediately helps guide a much more accurate therapy. And when you get the right drug to the patient faster, that directly leads to lower mortality rates and shorter hospital stays. Plus, it saves a ton on healthcare costs, because we're not just throwing expensive broad-spectrum antibiotics at the problem. Sometimes we can even report a likely genus, which helps narrow down that life-saving treatment decision even further.
Okay, take this for example. A patient has a deep, really foul-smelling wound. The doctor suspects gas gangrene, which is this devastating infection from Clostridium species that can lead to amputation. A gram stain of the gunk from that wound can give an answer almost immediately.
For gas gangrene, there are 3 classic signs you look for. First, there's a total, shocking absence of inflammatory cells, like neutrophils. Why? Because the toxins from the bacteria just obliterate them. Second, you see these very characteristic short, thick, gram-positive bacilli. And third, you almost never see spores because they just don't form inside the body. That combination, it's pretty much a slam-dunk diagnosis.
Okay, so now let's see how this pattern recognition idea works in a totally different situation. Sometimes, a diagnosis isn't about finding one specific bad guy bacterium. It's about seeing that the whole microbial neighborhood is changed, and bacterial vaginosis, or BV, is the perfect example of this.
The difference here is just night and day. On the left, you've got a healthy sample. See how it's dominated by those big, protective, gram-positive rods of lactobacillus? Now look at the right. In bacterial vaginosis, that healthy flora is just gone. It's been replaced by this chaotic mess of tiny gram-variable rods and kermed bacteria. The diagnosis is made just by seeing that dramatic shift from microbial order to total chaos.
And that's also why we really stress that describing the likely genus is so much more useful than just talking about morphology. If you say you see gram-positive cocci in clusters, that screams staph. If you say chains, you're thinking strep. For gram-positive rods, their shape might hint to Clostridium, Bacillus, or diphtheroids. These little details give doctors a huge leg up.
The way we use the stain can also change depending on the sample type. For instance, in unspun urine, if you see just one bacterium per oil immersion field, that strongly suggests a pretty significant infection, maybe like pyelonephritis. And while we don't do it routinely for stool, in suspected cases of something like cholera or campylobacteriosis, the gram stain can be uniquely diagnostic.
But look, all of this amazing diagnostic power means nothing if the sample itself is garbage. And that brings us to the final, and maybe one of the most critical roles of the gram stain. It's our quality control gatekeeper.
This all comes down to that old saying, garbage in, garbage out. For a sputum sample, we have to know if what we're looking at is a real infection deep in the lungs, or if it's just a sample full of spit. That's where something called the Q-score comes in. It's a system we use to actually quantify the quality of the specimen before we waste any more time on it.
So here's how it works. It's pretty simple. We look at the sample under low power, neutrophils.
Those are inflammatory cells. They tell us there's a real immune response going on, so they get a positive score. On the flip side, squamous epithelial cells, which are the cells that line your mouth, tell us the sample is contaminated with saliva, so they get a negative score.
The process is easy. You count the neutrophils and give them a score from +1 to +3. Then you count the squamous cells, give them a score from -1 to -3. You just add them up to get a final Q score, and that number tells you if the sample is even worth culturing and how many potential pathogens you should bother looking for. It just makes sure we're focusing our efforts on samples that are actually clinically meaningful.
Let's talk about the classic pitfalls. The biggest one, the most common error by far, is leaving the alcohol decolorizer on too long. You do that, and you can literally wash the purple stain right out of a gram-positive organism, making it look falsely pink. But on the flip side, if you don't decolorize enough, gram-negative bugs can trap the purple dye and look falsely gram-positive. Even something as simple as not leaving the iodine on long enough can mess up the whole reaction. It's a real delicate balance at every single step. And that brings us to our final section, which is just as important as anything else we've discussed. To really use a tool wisely, you have to know its limits. You have to know when not to use it, and you have to know what a negative result really means. So first off, some specimens are just not a good match for this test. For a stool or throat swab, there's so much normal bacteria that trying to find the one bad guy is like finding a needle in a haystack. And then there's blood. You'd think someone with a bloodstream infection would have tons of bacteria, but the numbers can be surprisingly low. We're talking maybe fewer than 10 organisms per milliliter. The chance of one of those tiny bacteria ending up in the single drop you put on a slide, it's minuscule. That's why we do blood cultures first, to let them grow to a level we can actually detect. Next up, remember that the entire gram stain works because of the bacterial cell wall, right? That peptidoglycan layer? Well, what happens if a bacterium just doesn't have one? Organisms like mycoplasma lack a cell wall entirely, so the dyes have nothing to grab onto. To the gram stain, they're basically invisible. Other bacteria are tricky in different ways. Some, like chlamydia, are masters of disguise. They actually live inside our own cells, so the stain can't even reach them. Then you have organisms like mycobacteria, which cause tuberculosis. They have this thick, waxy cell wall that's like a raincoat. The gram stain dyes just slide right off. They need their own special kind of stain. And finally, some bacteria are just too darn skinny. Spirochetes, like the ones that cause syphilis, are so thin that even if they could pick up the stain, you just can't see them with a standard light microscope. They're below the limit of what the microscope can resolve. A couple of other important details. The gram stain colors both live and dead bacteria, so it can't tell you if an antibiotic is working. You might just be looking at the ghosts of infections past. Also, things can get a bit ambiguous. In an older culture, the cell walls of gram-positive bacteria can start to break down, so they stop holding on to that purple stain and can look pink or gram-variable. So after going through all the things it can't do, we come back to that big question. Why is the gram stain still a cornerstone of modern medicine? Well, it's because the value of that immediate, actionable information, gram-positive or gram-negative, cocci or bacilli, clusters or chains, that you get in minutes for pennies, it's simply unmatched. It's the perfect example of a test whose massive strengths far, far outweigh its known boundaries, and that's why it has secured its place in the lab for a long, long time to come.